Welcome back to the Rebel Core Content Podcast. Core content for anyone, anywhere, and just in time. This is Swami, and I'm back with our in-house toxicologist, Dr. Sanjay Mohan. Sanjay, we've chatted about alcoholic ketoacidosis, caustic ingestions. What do you got in store for us today?
Hey, Swami. So today we're going to be talking about a drug class called methylxanthines.
The classic medication when we think about methylxanthines is theophylline, which I got to be honest, Sanjay, I've read about theophylline. I know about theophylline. I have never prescribed theophylline to somebody in the emergency department or for them to go home with. So why are we picking this topic?
So methylxanthines are a drug class that include not only theophylline, but caffeine and theobromine as well. Now, in today's world, with an ever-increasing use of either coffee, over-the-counter stimulants, or energy drinks, I think this is something that every ER doc is going to come across at some point or another. And if it's not on your differential, you're going to forget about it.
Let's start a little bit with how these medications work. Again, theophylline is our classic. Caffeine's mostly what we're going to be talking about because it's mostly what we're going to see exposures to. How do the drugs actually work in the system?
Historically, methylxanthines were the drug of choice for things like asthma and COPD before we had better things for lung disease, and that's specifically due to their beta agonism. However, given their multitude of side effects, they've been replaced by more targeted therapies, such as beta-2 agonists like albuterol and anticholinergics like ipratropium. In the healthcare setting today, caffeine is still used in our neonatal ICUs for apnea in preterm infants. And as I mentioned before, I think in the ER, you're probably going to see methylxanthine toxicity in the context of significant coffee or energy drink intoxication, which is specifically caffeine-mediated. When it comes to the physiology, there are three major mechanisms that you need to think about: beta agonism, adenosine antagonism, and phosphodiesterase inhibition.
I think that narrow therapeutic window is a lot of why we abandoned these medications. And I think they were abandoned kind of right before I started residency. So people talked about them rarely. I think I remember one or two times someone pulling out theophylline in a COPDer who maybe was refractory to our standard medications and standard therapies. Of course, that standard therapy didn't include things that we use now as standard therapy, like non-invasive positive pressure ventilation. So who knows whether there's really much of an indication for them. But that caffeine overdose or the caffeine intoxication or unintentional caffeine overdose, I think is pretty common, especially in younger patients who just don't quite understand the fact that caffeine is a drug and in overdose, it's going to cause problems. So let's talk about that set of patients, the patients who have that unintentional caffeine overdose. How are they going to present to us in the ED?
Right, and I think the best way to break this down is by looking at those three mechanisms we just alluded to. In terms of beta agonism, these patients will have an elevated lactate, hypokalemia, hyperglycemia, and tachycardia. Given the degree of ingestion, they may also exhibit some anxiety, tremulousness, and most often than not, will have some degree of GI disturbance, nausea, vomiting, and diarrhea. In terms of the adenosine antagonism, you may actually see supraventricular tachycardia that is unresponsive to pushes of adenosine. It's essential to note that adenosine is the body's endogenous anticonvulsant. As a result, adenosine antagonism or blockade may lead to seizures and/or status epilepticus. And lastly, and this might be the unifying factor, at least in my head, phosphodiesterase inhibition may lead to peripheral vasodilation and as a result, a wide pulse pressure. So as opposed to the 120s over 80s millimeters of mercury, you may see 120 over 30, 120 over 40, and as a result, resultant hypotension.
That last piece is kind of interesting because much of this is the beta agonism. I mean, let's be honest. I think sometimes when we drink coffee, we're trying to titrate to a little bit of that beta agonism, maybe not all the way, but I have definitely gotten into trouble with, 4 or 5 double espressos and feeling a little tachycardic. And I probably have a little bit of a lactate too. But that phosphodiesterase inhibition helps to differentiate this a little bit from a lot of the other drugs that we know cause beta agonism. So a lot of our sympathomimetics, if you take cocaine or crack, or if you use methamphetamines, that's going to cause tachycardia, but also hypertension. That's the classic pair that we see. Here you're saying that we could see normotension, but with a wide pulse pressure. That's a little bit different than what we see with our classic sympathomimetic toxidrome, which kind of bridges me to the next point. If the primary component of the overdose is going to be beta agonism, aside from that pulse pressure variation, is there anything else that we can use to differentiate this from a sympathomimetic, or does it really not matter to differentiate the two?
So it definitely matters to some degree. And I'm going to say something that we probably all heard since our first day of medical school. The vast majority of the diagnoses you can make are going to be by what? History and physical. But the fact of the matter is, as an ER doc and as a toxicologist, patients love not telling me the truth. So, as you just mentioned to Swami, I think the biggest delineating factor is probably that wide pulse pressure and normotension. Alternatively, these medications, I think, have a greater propensity to leading to seizures than your general sympathomimetic.
So diagnosis might not be clear early on. We're going to have to treat them without that specific history if we don't get it. We might get it later. Maybe a family member or a friend comes in and gives you a little bit more history. Maybe the patient becomes more forthcoming with what happened. But when we have this sort of a toxidrome in front of us, where we're not sure, could this be a methylxanthine? Could it be a caffeine overdose? Could it be a sympathomimetic? What am I going to do to start management?
Right. And this is right within our wheelhouse. If they're incredibly sick in the sense that they have lethal dysrhythmias or in status epilepticus, do what you do best, ABCs and IVO2 monitor. For patients that are a little less sick, activated charcoal is a mainstay of treatment in order to reduce systemic absorption. Now, the kicker is the patient obviously has to be able to tolerate PO, and the vast majority of patients will have some degree of GI distress. Why do we give charcoal? Methylxanthines undergo something called enterohepatic circulation, which means these drugs are metabolized by the liver, get secreted into the bile, stored in the gallbladder, and then re-released back into the gut. And this is kind of cool because even if a drug is not in your gut in real time, giving charcoal will enhance elimination by drawing it out of systemic circulation. This is a concept known as gut dialysis. Hemodynamics can be supported by a judicious amount of crystalloid, alpha agonism in the form of phenylephrine, and then short-acting beta or calcium channel blockers such as esmolol or diltiazem in the setting of supraventricular tachycardia. And just remember, if the adenosine doesn't work, that should be another key that this may be a methylxanthine toxicity. Supportive care in the form of electrolyte repletion is always necessary. And then lastly, for patients in refractory shock or seizures or life-threatening dysrhythmias, hemodialysis should be considered.
The nice thing about this is, again, if you don't make that differentiation or you can't make that differentiation between a sympathomimetic and one of these methylxanthines, it is good supportive care up front. If they can take charcoal, give them charcoal. If they need a little bit of something to take the edge off of the tachycardia, you could give them a benzodiazepine. If they have SVT, you can use beta blockers and calcium channel blockers. I mean, honestly, I don't use a lot of adenosine anyway for SVT, so I can still use my calcium channel blockers, which I like. We're going to support their hemodynamics. Again, that might be the key when you're like, wow, this really looks like a sympathomimetic. Why is the pressure 110/30? That's an odd pressure for enough of a cocaine or crack cocaine overdose to see tachycardia, but I'm not seeing the hypertension that goes along with it. That might be the key. But if you focus on good supportive care, you're going to take care of these patients really well. And then, you're going to have to wait it out. A lot of the times you're simply going to be waiting for the patient to move that caffeine out of their system. Anything more specific that we need to think about in terms of the diagnosis?
Yeah, and I'll be quite honest. This is a diagnosis I made 2 or 3 times in fellowship, but I kind of fell backwards into it. The patient looked kind of okay, had a wide pulse pressure, was an SVT, and we gave adenosine once, twice, and it didn't work. We went back to the patient and ultimately landed upon caffeine. So just remember, just keep it on the differential, and sometimes it's going to be there.
Excellent. We don't ask the question, you're not going to get the answer. So it's always a good one just to keep in the back of your head when you see patients who are coming in with this constellation of symptoms. Sanjay, before we go, let's leave everyone with some take-home points.
Methylxanthines are a drug class that include caffeine, theophylline, and theobromine. The 3 main mechanisms that account for the clinical presentation of methylxanthine toxicity are beta agonism, adenosine antagonism, and phosphodiesterase inhibition. Beta agonism will lead to elevated lactate, hypokalemia, hyperglycemia, and tachycardia. Adenosine antagonism may lead to seizures and/or supraventricular tachycardia. And phosphodiesterase inhibition may lead to peripheral vasodilation and a wide pulse pressure. Lastly, treatment includes activated charcoal if the patient can tolerate PO, short-acting beta or calcium channel blockers such as esmolol or diltiazem in order to reduce the heart rate and increase filling time and thus peripheral perfusion. And lastly, hemodialysis should be considered in cases of refractory shock, dysrhythmias, or seizures.
All right, that's all for the Rebel Core Content Podcast this week. We'll be back in 2 weeks on another cast. In the meantime, don't forget to pop on over to the site, check out all the great posts from our faculty, and until next time, stay safe.